Hello everyone. Um, Here is Emad Magdy speaking to you. Our lecture today will be an introductory lecture of the week about the mental dysfunction in ER. This is the theme of this week. We will cover and hit multiple points in this presentation: the acutely confused patient or the acutely weak patient presentation in ER. It's a very challenging presentation because it carries a very wide spectrum of differential diagnoses, both in the metabolic and neurological, systemic and localized. So we will focus this week through the lectures and seminars how to approach this type of patient. Let's start with the patient with diminished consciousness. As a theoretical background, we should know that the conscious state is maintained by the integrity of two structures, the cerebral hemisphere and the reticular activating system. The cerebrum helps to maintain consciousness and alertness, and at least one hemisphere should be intact, as well as the reticular activating system must be functioning normally to maintain consciousness. The ability to maintain the consciousness and the cognition can be influenced by the damage in the hemispheres or the reticular activating system. This damage may be quantitative or qualitative. So when blood flow or amount of nutrients such as oxygen or sugar supplying the brain decrease, or when toxic substances impair the brain function. So the perfusion to these structures can be impaired by quantity, as stroke syndromes or ischemia, or on the other hand it can be qualitative if the amount of nutrients or such as oxygen or sugar can be withheld from these structures, so the brain damage will be the result and the loss of consciousness and the alertness. And this is why the presentation is so confusing between the metabolic causes and the neurological causes, the structural causes and the metabolic causes, like the general causes, general toxicities or drug toxicities, hypoglycemia, electrolyte disturbances, all these are affected the mentation. Again, it's a time to apply the three principles we used to use in the last week. Any presentation in the ER, the diagnosis versus resuscitation, the scenarios outside the emergency department, and the logic rather than the lists. Which type of lists we can use in differential diagnosis of this presentation? Sure, in the acute confusion or the cerebral impairment, we should think about the resuscitation first, because the brain contains the major centers which control the blood vessels, control the respiration. So any disturbance which can affect these centers can affect the patient life in a threatening way. So we have the famous Glasgow Coma score, and we should all know how to calculate the Glasgow Coma score for the patient, because again it's the unified language between us is to know if I presented to you a case with confusion, the first question come to my mind: what is the Glasgow Coma score of this patient? Because all the management and all the thinking can be affected by this score. The patient need oxygenation or not, need assisted ventilation or not, need to support the hemodynamics or not. So this Glasgow Coma score affected by the eyes, verbal and motor responses of the patient. I know that you studied before just to memorize it, but we should know that the severe neurological conditions may affect the upper airway tone, respiratory drive, vasomotor and cardiac rhythm. Also, if the cause of brain dysfunction is systemic, this will need to be dealt with. Therefore, it's a paramount that airway breathing calculation circulation algorithm is given due respect. Okay, so this is number one. Number two, logic rather than less. So if we try to think about the causes of the acute confusion, again, a very wide spectrum will come to our mind, but this is not the usual way we try to think about the emergency presentations. We have to categorize the patients into patients with a structural brain problem or a secondary brain problem. This is number one. So structure means that the problem is in the brain itself, as we said before, the cerebrum or the brain stem or the reticular activating system, or this affection of the brain is secondary to systemic disease, secondary to secondary cranial disease, or secondary cranial disease systemic or metabolic. Okay, this is number one. Number two is to know if this structural change can be seen radiologically by imaging or can't be seen radiologically. So this is number two. Number one and number two. Number one, is there any evidence of a structural brain lesion or not? Is there any evidence of lesion obvious in imaging or not? Those are the two. How can we judge this? In the secondary cranial disease, systemic hypoxia, anoxia, hypotension, hypothermia, simply we can do general examination. So by general examination, simply we can determine if the patient is hypoxic, hypotension, hypothermia. It's very simple. And if we like to know that this structural change is evident on the imaging or not, simply we will do CT or MRI or some invasive techniques. You have a seminar this week about the neurodiagnostics in ER. How can we benefit from the CT and MRI? Which of them is more sensitive? Which of them is less sensitive? Which of them is related to such a disease? A complete seminar about the neurodiagnostics in ER by Dr. Osama. You will find it in the curriculum, inshallah. And those the primary cranial diffuse disease where no structural lesions will be obvious on imaging, or secondary cranial disease like the alcohol, drugs, hypoglycemia, endocrine disturbances, liver problem, decompensated liver, decompensated kidney, non-cranial infection. All these will be prone through the history examination and the investigation. So what are the items we will concentrate on? The history examination and investigation, that we will discuss in the next slides, inshallah. But I'd like again to announce this is a matter of logic rather than less. So number one, is there a structural brain lesion or not? Number two, if there is this structural brain lesion can be diagnosed by imaging or not? Very simple. What are the important items in history examination and the investigation? Let's pass to the history. A brief history from the relatives of the patient should include those questions. Number one, the course of the confusion. The acute confusion sure is different from chronic from gradual confusion. We all know that the acute confusion is is accompanied by the structural brain lesion more than the metabolic causes. The metabolic causes is usually gradual. If there is preceding hemiparesis, headache, trauma, fit, again, those why I asked you to know the history items that can suspect structural brain lesion. So preceding hemiparesis mean one cerebral hemisphere affected. If it is metabolic or general, the two hemispheres will be affected. So the hemiparesis is not a typical sign of metabolic encephalopathies. Drug or alcohol intake is very, very important. We will discuss in the last two slides of the lecture, the drug toxicities like the methanol, like the SSRIs for the psychosis and the depression, the alcohol intake, the methanol toxicity, ethanol toxicity, all these are possible causes. History of cancer. Why history of cancer? Because cancer can, the confusion can be a sign of brain metastasis. The confusion can be a side effect of the cancer treatment, like some chemotherapies. The cancer can be treated with therapies that cause electrolyte disturbances like hypokalemia, hypomagnesemia, hypocalcemia. All these are side effects of the. So history of cancer is very important in to ask in the patient with confusion. Diabetes, sure, because we have a wide spectrum of diabetic comas. We have the hypoglycemic coma, hyperglycemic comas, diabetic ketoacidosis, hyperosmolar, liver disease, decompensated liver disease. And in the history, we should ask about the decompensated liver disease, not only the liver disease, because as a common thought to live with the patient, and this patient have a liver disease, okay, but is this patient have a symptoms of decompensation? And decompensation may be parenchymal and may be vascular. Parenchymal decompensation is this patient experiencing hepatic encephalopathy before, if the patient is ascitic, if the patient is have a bleeding tendency, have a hematemesis, a melena, have a skin manifestations of decompensated liver disease. Also the renal disease should be in the end stage renal disease. So if the patient is known to be a renal patient or chronic kidney disease patient, if this patient have a multiple urinary tract problems before, if the patient is diabetic and have a retinopathy and proteinuric, all these are important questions to ask in the history. In examination, we have multiple points, very important points we should localize. So we have certain aims we should search for in the examination to assess the possible cause of the confusion and to differentiate between the neurological and the metabolic causes. Full body inspection for features of trauma, fundoscopy, cranial nerves and motor function, including power, tone and reflexes. Sure, it's very important. If I'd like to talk about the fundoscopy, the fundus is very important to diagnose some brain problems like the brain tumors, like the cavernous sinus thrombosis, so the fundoscopy is very important. Also the diabetic kidney disease, the diabetic retinal disease can be accompanied by diabetic kidney can be accompanied by diabetic retinal disease. The malignant hypertensive changes is a very important, very evident in fundoscopy. So if I suspect that this patient is hypertensive encephalopathy or have a malignant hypertension, I should examine the fundi. So the fundoscopy is very important. Cranial nerves examination is very important, and motor function, including the power, tone and reflex. The power, sensory and the cerebellar and visual assessment may not be possible due to lack of cooperation. So we have, in the confused patient, we have some problems with the motor assessment. Okay. The signs of meningism is very important, because one of the important causes of mental dysfunction is the brain infections like the meningitis, encephalitis. So the signs of meningism, the nuchal rigidity, knee extension, patient supine with hip and knee preflexed. Any sign, sure, of decompensated liver, kidney and heart disease. So I should assess for the Fowlerian status, neck veins, patient is orthopnic or not. This is for the heart. Ascites, edema lower limb, splenomegaly, presence of spontaneous bacterial peritonitis. All these are important tasks in the examination. Primary cranial infections may manifest as meningitis and encephalitis, as we see. One may also become acutely encephalopathic from widespread non-infective inflammatory vascular lesions. So the brain inflammation is not only caused by the infections. We have autoimmune inflammations, and with both of them, changes may or may not be evident on cranial imaging. We should know that we have also the CSF analysis as a tool of diagnosing these disorders, and can help us to manage the treatment, start antibiotics or antiviral agents. Again and again, all the neurodiagnostics, the imaging and the CSF will be discussed thoroughly in a separate seminar in this week. The most important signs of lateralization, this is Sir Papinski, are those signs help us to differentiate between the first task we mentioned in the algorithm, the structural lesions and the general lesions. Structural lesions are usually accompanied by signs of lateralization, like the unequal pupils, deviation of the eyes, facial asymmetry, unilateral hypo or hypertonia, asymmetrical deep reflexes, unilateral extensor plantar response, Papinski sign, unilateral focal or Jacksonian fits. All these are helpful in the answer of the first question, if there is a structural brain lesion or just a general non-structural or no evidence of a structural brain lesion, is a general systemic cause, not a neurological cause or a structural brain problem. Okay. Pupillary examination deserves special mention. Why? Because the pupillary pathway are resistant to the metabolic insult. This, you should deal with this information as not absolute. We have, as I will mention in the next slide, we have some changes in the pupil which can be of metabolic in origin. It's not an absolute sentence, but usually the pupillary affection is neurological more than metabolic, and we should exhaust ourselves to exclude all the neurological causes before telling the patient or telling the reporter that there's a metabolic problem and should search for metabolic problem. Okay, so the identification of absent pupillary reflexes usually implies a structural pathology. The brainstem areas governing conscious level are anatomically close to the areas controlling the pupils, and so pupillary changes help to identify brainstem pathology causing altered conscious level. One of the tasks of the neurologist after the suspicion of the structural lesion is to know the site of lesion, and we have some challenges in the diagnosis of the site of lesion. It depends on the clinical and radiological. In the brainstem lesions are not so evident in the CTs and need MRI, and most of the ERs cannot offer MRI for all the patients presented with acute confusion or query ischemic insult to the brain or to the brainstem. So one of the brainstem reflexes and the pupillary reflexes are of great clinical importance to diagnose the site of ischemia or a structural brain problem. And this is the interpretation of pupillary response and eye movements. Very important. Those highlighted with the red square are the changes which can be presented or can be present in the metabolic encephalopathies. But pupils fixed in mid position, all of these are mainly midbrain dysfunction or central herniation, maybe severe metabolic depression by drugs and toxins, unilateral pupillary dilatation and pupil underactive to light. It's a structured brain lesion. The eye movement also, eye abnormal pupillary and oculomotor signs, primary brainstem lesion, gaze preference to one side, brainstem lesion or sepral hemisphere lesion at the same side. So the pupils and the eye movement is very, very important signs to differentiate and to localize the structured brain lesion. And don't forget, despite that the general rule that the pupillary reflexes or the pupillary changes is helpful and mainly is an indicator of a structural brain leisure, we still have some signs of pupillary changes in the metabolic disturbances, but the severe metabolic disturbances. Again, meningitis versus encephalitis. How to differentiate clinically? Those are the differentiating point. From the name, meningitis mean that the meningism or the meningeal irritation signs will be the most evident one. But encephalitis, it means affection of cerebral hemisphere. So the focal neurological finding or the structured brain lesions will be the hallmark of this encephalitis. So weakness, visual disturbances, aphasia, cerebral finding, behavioral changes, the hallmark of the encephalitis. May develop in meningitis or not, but the meningeal irritation is here the hallmark, and here sometimes fever and leukocytosis in both of them, mental alteration in both of them, and seizures also in the encephalitis more than the meningitis, again according to the it seems logic according to the anatomical diagnosis. If muscle tone and deep tendon reflexes and the response to the Doll's eye maneuver are normal, suspect psychogenic unresponsiveness. And this is again one of the common presentations or the common differential diagnoses of abnormal mentation in the ER. Those for the history items and for the examination. So for the history, to ask about the acute or chronic, to ask about the alcohol and the drugs, to ask about the history of diabetes, complicated diabetes or not, symptoms and signs of decompensated liver, symptoms and signs of decompensated heart or congestive heart failure. Those four symptoms, four signs. So number one, the signs of lateralization. Why? Because it differentiates between the focal brain affection and the general brain affection. Then the pupillary and eye movement reflexes, the estimation of the glaucoma score and determination of resuscitation. Those are the main points I'd like to revise it. What are the important investigations? Yes, again, the cranial CT are essential in stroke, while MRI scans are useful in variety of cranial and spinal cord lesions. CT is sensitive in hemorrhagic stroke, while MRI with diffusion for ischemic stroke. A spinal cord MRI should be booked as an emergency when cord compression is suspected, and nerve conduction studies and EMG are useful to confirm the diagnosis of Guillain-Barré and differentiate peripheral nerve from nerve root pathology. So again, this type of the metabolic and general causes we don't need in the ER. Those are the lists, but we don't have these lists in the ER. We should have our own logical lists. Sorry. And this is another type of list which is very logic. It lists the causes of the acute confusion according to the site or according to the residence of the patient. If I am in the emergency department, I should think primarily or exclude primarily the medications, the organic disorders, the electrolyte disturbances, the misuse of alcohol. If I in intensive care unit, the organic disorders come first, the large number of medications, the electrolyte imbalance. If I am in general hospitals, the infections come to the first position. If I am in a psychiatric unit, the use of large number of medication and psychiatric medication, ictal and post-ictal states, behavioral changes. So according to from where the patient come, our thinking may differ and our priorities may differ, because we know that in each place of this we can have some common causes of confusion rather than the others. And this is number one, the acute confusion. The presentation number two, the acutely weak patient. The term weakness is a very confusing term between weakness, fatigue, and tiredness. All these can be confused when we try to present a patient or prescribe the patient presentation. The term weakness will often be used by patient for a variety of complaints, but weakness should be reserved to the meaning of reduced motor power. So many patients will come or complain from weakness when in fact they are fatigued or lethargic. So weakness equals motor power affection. Okay, it is reasonable to infer reduced motor power when weakness is present without significant tiredness. This should be contrasted with fatigue and lethargy, where the diminished power is generalized, accompanied or caused to be with significant tiredness. So the initial questioning, do you feel should be like this? Do you feel weak because you are tired, or do you think that you have significantly lost your muscle power? Again, it's not a simple question. It's not, most of us will do some effort to differentiate between this, because to separate between the fatigue and lethargy and the weakness is not a simple task, and even the best clinical history taker and best historian will not differentiate between weakness, fatigue, and lethargy easily. And those are the determined definitions of weakness, fatigue, and lethargy. Weakness referred to loss of muscle strength. Weakness may be generalized or may affect one muscle or group of muscles exclusively. Disease of the neuromuscular system, injuries, metabolic disease, and toxins can all cause muscle weakness. Signs and symptoms of weakness can include difficult doing daily tasks such as grooming or writing problems or get a loss of balance. Fatigue is another entity. Fatigue is in medical terminology referred to the state of reduced capacity for work, exercise intolerance. This is the fatigue. Most of the causes of tiredness are also associated with fatigue. Lethargy is a state of lacking energy. People who are experiencing fatigue or tiredness can also be said to be lethargic because of low energy. And both all the medical conditions that cause lethargy can lead to tiredness and fatigue. So the simplify the mission, we have to separate between the weakness and the fatigue, lethargy, tiredness, because there is no benefit to differentiate between fatigue, lethargy, and tiredness, because all these the conditions that cause them all. But the weakness means muscle affection, muscle power affection, maybe focal, maybe diffuse. So if we try to apply the three principles, scenarios outside the department, logic rather than less, and diagnosis versus resuscitation, again the logic is very important. So we have here multiple scenarios, and these scenarios related to the certain spectrum of causes, because again the acutely weak patient carry a very wide spectrum of differential diagnosis. So if the patient have fatigue or lethargy leading to generalized weakness, most of them will be metabolic causes more than neurological one, like the chronic heart failure, chronic lung disease, sleep disorders, anemia, chronic kidney disease, diabetes, chronic infection. Loss of motor power leading to generalized weakness, it's mainly neurological problem, myasthenia, post-infectious inflammatory polyneuropathy, Guillain-Barré acute myopathy, myositis, rhabdomyolysis, and those are the other neurological scenarios. So hemiparesis or hemiplegia, as we said in the confusion, hemiparesis or hemiplegia, it is a sign of structural brain lesion. Monoparesis or monoplegia, paraparesis, paraplegia, quadriparesis and quadriplegia, all these this is a presentation based differential diagnosis, not vascular, infectious, traumatic. This is not the type of the ideal type of lists which can benefit me in the ER. Important history tricks, as we did in the confusion. This again, the history should prescribe good the course, the onset, and the distribution of weakness. And in most cases, rapid onset of weakness suggests vascular pathology, whereas an more slightly longer course may suggest an infective and inflammatory condition. So a very simple information can help me to differentiate between very wide spectrums of differential diagnoses and may help me to reduce the investigations and reduce the time to diagnose the patient. So rapid weakness is coping with the vascular pathology, and the over hours and days suggest an infective or inflammatory condition. Associated pain is a consequence of nerve root or peripheral nerve involvement. This occurs in with acute myopathy. There is maybe muscle tenderness. So pain again is this weakness is accompanied with, is it a myositis or neuritis with the problem or not. So the pain again is very important and very simple idea to know. Sure, drug history is very important. Chemotherapy, SSRIs, antidepressants. Family history may uncover inherited muscle disorder. Risk factor for stroke like hypertension, hyperlipidemia, diabetes, alcohol intake, and smoking history should be documented. Those are the history points important in the acute weakness or acute weakly patient. The examination will not differ from the acute confusion, because again it's a metabolic or neurological. I should check for this the investigations also, but here maybe the electromyography, may nerve conduction, as we said. So slightly shared criteria between the two presentations, and this is a challenge in this week, is that we have multiple causes and multiple presentations, and we should know what are the milestones which can differentiate between those very wide spectrum of cause. We have special situations in ER like the delirium in the geriatric patient. Delirium is a type of confusion in the geriatric population which is very common. We have again a terminology problem. We'd like to we will try to define the delirium, but the confusion is a type of hypoactive delirium, because we have another form of the delirium which is the hyperactive delirium associated with irritability. So the delirium in acute confusion is the hypoactive delirium. So the acute and the fluctuating onset of inattention with disorganized thinking and altered level of awareness, this is the delirium. This is different from the dementia, because the dementia is a slow progressive process. The delirium happens acutely. In the elderly, 70% of delirium is initially hypoactive, which can delay its detection in the emergency department, but the hyperactive delirium is characterized by agitation, restlessness, aggressiveness. Hypoactive delirium is characterized by motor retardation, apathy, slowing speech. Patient can appear to be sedated. So the delirium should be not confused with the dementia. The delirium is an acute process. Dementia is a chronic process. What are the risk factors of delirium? Very important. The extremities of age is very vulnerable to altered mentation due to dehydration, due to undertreated pain, prolonged stay in the emergency, unable to mobilize from the bed for a long time, neglected in home, dehydration as we said. So dehydration, fever, untreated pain, all these can be a cause of delirium in the extremity of age, and those again are the major causes. You can memorize it like that. We have drugs, infections, metabolic, environmental, structural, but don't forget that urinary retention and constipation even can be a cause of delirium in elderly. So the prolonged urinary retention or the constipation, fecal impaction can be a cause. It's not only CNS events, it's not only bleeding, strokes, no. we have here multiple more common causes like the dehydration, fever, the drugs, the infections. All these can be a cause of delirium in the elderly. The killer comas, or the as I mentioned in the first part of the lecture, the methanol and the SSRI. Why I specify those? Because those are one of the commonly presented drug toxicities in the ER. I'd like you to know, when to suspect toxic alcohol ingestion, the methanol cause metabolic acidosis, so we will see cosmic breathing, abdominal pain, ocular complaints. Methanol is toxic for retina and optic nerve, leading to snowstorm vision, flashes, and eventually blindness if not treated. We should know that methanol is a dialyzable drug, so in the patients with high levels of detected methanol, or a patients with ocular toxicities, or patient with severe neurotoxicity, the hemodialysis can be an option for treatment. The serotonin syndrome, or the SSRIs, the SSRIs can be presented with toxicity in the form of shivering, hyperreflexia, increased temperature, vital sign instability, encephalopathy, restlessness, and sweating. Lastly, I will just hit 2 or 3 issues in the hepatic and diabetic comas. In the hepatic comas, I'd like you to know that the comas from the hepatic affection is not only through the scenarios that we have a chronic liver disease, cirrhosis, portal hypertension, and then the patient come to end stage liver disease and then hepatic encephalopathy. I'd like you to know that we still have place for the acute liver decompensation, and those are the most common causes of the acute liver decompensation, like the drugs, viral infections, vascular problems, metabolic, and indeterminate. The acetaminophen is very important. The hepatitis hepatitis A and B, the vascular problems like shock, tumor infiltrating the liver, the acute fatty liver of pregnancy. All these are causes of acute liver decompensation, and it's very important to know that the liver functions can be acutely decompensated in hepatitis, and one of the signs of the prognosis of this liver pathology is if there is acute, if this acute decompensation is accompanied by bleeding disorder or bleeding coagulopathy. The patient with acute liver failure and coagulopathy carry a more bad prognosis than the patient with acute liver failure and intact coagulation system. Some other issues in the liver problems or the liver encephalopathy. Physicians often fail to initiate specific treatment and monitoring for hyponatremia, as the role remain widely underestimated. So we know that the advanced liver disease is accompanied by hyponatremia from the pathophysiology of the hepatorenal syndrome and of the decompensated liver disease. Hyponatremia is an indicator of portal hypertension and well known to be associated with poor prognosis in the MELD score. And the chronic hyponatremia, which is typically seen in patients with cirrhosis, may appear asymptomatic in patients with cirrhosis. Hepatic encephalopathy can be worsened or might be even triggered by hyponatremia. So to check the serum sodium is one of the important things for diagnostic purpose and for prognostic purpose. So the patient again with hyponatremia, hypotension, and coagulopathy and renal impairment, all these are bad prognostic signs in a patient with advanced liver disease. Diabetes. I will end with the diabetes inshallah. Diabetes, type 2 diabetes can have many mechanisms to cause cognitive dysfunction. they have impaired neurogenesis, blood-brain barrier dysfunction, inflammation, hyperglycemia, insulin resistance, vascular dysfunction. All these can cause cognitive impairment. And we have the hypoglycemic coma and the hyperglycemic coma, and this table highlight the main differences between the diabetic ketoacidosis and the hyperosmolar non-ketotic coma. And sure, the main the main differences will be the signs of ketosis, the cosmol breathing, the areas, the acetone breath, can differentiate between both of them, but the main differentiating point is that the degree of dehydration is more and more in the hyperosmolar less than the DKA, and the onset of DKA is acute, and in the hyperosmolar it is an insidious onset. This is number one. Number two, the DKA is more common in type 1 than in type 2, but hyperosmolar is more common in type 2 than in type 1, and the DKA in type 2 should be accompanied by a precipitating factor like sepsis, like dehydration, like MI. So when we diagnose the patient with DKA where he is type 2, we should search for the triggering factor. Is this systemic infection, sepsis, dehydration, severe dehydration, or MI? We should do ECG to diagnose routinely in any patient diagnosed with DKA and at the ER, and those are the laboratory differences. Some comments, which is very important: the electrolyte disturbances I suspect in the DKA. So patients with DKA frequently present with significant leukocytosis, a leukocyte count greater than 25,000, or the presence of greater than 10% of neutrophil band in cell is seldom seen in the absence of bacterial infection. In ketoacidosis, leukocytosis is attributed to stress, dehydration, and demargination of leukocytes. So not any leukocytosis in the DKA is attributed to the sepsis. Okay, so the above a leukocyte count above 15, not above 11 as we used to in the normal patient. The admission serum sodium may be low in the DKA due to the osmotic flux of water from the intracellular to extracellular space. To assess the severity and of sodium and water deficit, serum sodium may be corrected by adding 1.6 milligram deciliter to the measured serum sodium for each 100 milligram of glucose above 100. This is should be done in the calculation of serum sodium of the diabetic ketoacidosis patient. So in each increase in the serum glucose by 100 milligram per deciliter, we should add 1.6 milligram per deciliter for the milli equivalent per liter for the sodium. So we should calculate for the corrected sodium. An increase in serum sodium concentration in the presence of severe hyperglycemia indicates a profound degree of dehydration. So why we ask you to calculate the serum sodium or the corrected serum sodium? Because if you have a patient who is apparently normal serum sodium in the ER while he is in DKA or in severe hyperglycemia, it means that the real serum sodium is more than this or higher than this. And as we know that serum sodium not meaning the total body sodium, but mean the degree of the volemia. So hypernatremia indicates a severe hypovolemia and water loss. The serum potassium. The admission serum potassium concentration is usually elevated in patients with DKA and HHS. These high levels occur because shift of potassium from the intracellular to extracellular space due to insulin deficiency and hypertonicity, as well as acidemia and DKA. It's important to keep in mind that during insulin treatment, the fluid administration may result in hypokalemia. Okay, so the insulin, one of the actions of the insulin is the intracellular shift of potassium from the extracellular space to the intracellular space. Not all patients who present with ketoacidosis have DKA. As again, not all patients who are diabetic and present with ketoacidosis is due to diabetic ketoacidosis, because patients with chronic ethanol abuse may be a cause, or patients with starvation, lactic acidosis, decreased food intake or caloric intake, all of those can be presented with ketoacidosis, not diabetic in origin. Again, those are the references of the lecture. We will يعني take the mission of this week is to highlight again the different causes of the brain dysfunction in the ER. The presentation is so complicated. We have electrolyte disturbances, metabolic disturbances, neurological disturbances. So we can revise an academic background about the acute stroke syndromes, the status as epilepticus, the seizures. We will have a lecture about the seizures in ER. We will have a seminar with electrolyte disturbances which affect the cognition and the neuromuscular dysfunction. We can revise the acute stroke syndromes from previous, and in the PBL we will discuss the 2 cases of acute confusion, inshallah. Thank you and goodbye. Happy to receive any question on the email. Thank you again.